realize that there might be people on the forum or on the panel right now who have joined in, who are very familiar with this disease process, and some folks who may not be very familiar. So I would like to make it as simple as possible, but also hopefully make it as useful for people who have a more sophisticated understanding of the disease process. And I'm happy to take questions at any level. No question is off the table right now. We tried to focus on a very unique topic today, a very specific topic. It's about CAR T cell therapy. So there are two main concepts that I would like to talk about and explain. The first one is obviously what's CLL. Second one is what's CAR T. And then what are the issues with CAR T and why is everybody talking about it? So let's start off with CLL. Again, these slides are just here to help us. Again, I don't expect that we would be experts in this field. Nobody is an expert. So, but this is just to provide a very basic understanding once we get into the nitty-gritties of this whole CAR T process. But just to start off by what's CLL, CLL is the most common leukemia, blood cancer in our part of the world. And it's mostly a disease which is seen in older patients. Average or median age of diagnosis is around 70, 71. We are seeing more and more younger patients being diagnosed with it since we have access to modern diagnostic methods very easily. Anyone can order those. Most labs are able to run it, and you are able to get a diagnosis of this disease. In the past, this was diagnosed later on since our technology was not very sophisticated. So over the years, the age of diagnosis or age at diagnosis has slowly come down. It's not necessarily that the disease has changed. It's just that we're picking it up a little sooner than we were in the past. That raises another set of questions is anytime patients get a diagnosis of this disease, it's a big deal because it's basically saying that you have a blood cancer, chronic lymphocytic leukemia. Sometimes patients have mostly lumps in the body, and sometimes it's mostly disease in the blood. If it's only lumps in the body, it's can also be called as a lymphoma. And the term for that is SLL, or small lymphocytic lymphoma. Basically, the difference between SLL and CLL is that CLL is called the leukemia because it's mostly in the blood. SLL is mostly in the lymph nodes and historically was called a lymphoma, but they're essentially the same entities, and they're treated the same way, managed the same way. So that's in very brief, just an orientation of what CLL means and what SLL means. A lot of patients with CLL and SLL have slowly progressive disease, which means that they will not have any symptoms. The disease will slowly get worse over time. We don't treat patients early because we have found out that if we treat patients early, they don't necessarily live longer. If you have two patients diagnosed at the same time, one you treat right away after diagnosis, one you treat later, those patients will live the same amount of time. In some cases, if you treat early, patients may have more side effects from the treatment. So this is why historically, we have not had early treatment for patients with CLL. And this is why we feel that treatment should be started when the patients get to a point where the disease starts causing trouble or problems, symptoms, night sweats, fevers, big lymph nodes, or if the numbers are really off. those are some of the reasons when we start treatment for CLL. And fortunately, our patients do really well. There are now numerous treatments that can be combined in different ways, and the vast majority of patients tend to do really well. Having said that, as our patients are living longer and longer, we are seeing that a lot of our patients ultimately will stop responding to the treatment they have been prescribed. And at some point, those conventional treatments, so to speak, since they've been around for at least the last 10, 15 years, those treatments will stop being effective. Now, when that happens, we always have to look for newer options. And that's where CAR T comes in. So CAR T has been a phenomenal advance in the field, not just in CLL, but in multiple myeloma, in large cell lymphomas, in acute leukemia lymphomas, and in a number of other conditions. It's now being tested, and we expect that for a number of diseases, it will be approved. For example, synovial sarcoma, melanoma, neuromuscular disorders like myasthenia gravis, neuromyelitis, Sjogren's, lupus. It's being trialed in different ways, shape, or form for those conditions in which one shot of this treatment is able to cure potentially a number of patients with these diseases. So this is probably the most exciting treatment we've had in cancer initially, but not just in cancer, for a lot of diseases in which the problem is the immune function. So this is a one-shot fix for a lot of cancers and a lot of non-cancers that our patients suffer from. So by far in the last 5 years, this has been one of the most revolutionary advances in the field. And that's where there's been a lot of excitement. Now, why are we even talking about CAR T if it's just another treatment? Yes, it's exciting, but so what? There's so many exciting treatments. And the reason is that there are lots of misconceptions. There's lots of unknowns about CAR T cell therapy. And multiple groups have done multiple assessments over the years to see if patients are benefiting from these treatments. And it turns out that even in the US, where we have access to this fairly easily, most big centers, most larger cities have centers that have the ability to perform this groundbreaking, revolutionary treatment. But if we look at one disease, for example, we started off with large cell lymphoma, which is an aggressive type of lymphoma. There are 3 different CAR T products that are approved for this. And we saw that out of those patients who could potentially get CAR T, and a subset of them can be cured. Not everybody gets cured, but 40% can get cured. And those patients, yes, I will
Doctor,
definitely advance the slides when I get there. Absolutely got it.
perfect.
Yeah, no, I'm not there yet. So I know how to advance it. I'll definitely get there when I'm there. So I was just trying to lay the background. So all right, so the point I was trying to make was we looked at large cell lymphoma patients, and we actually found that less than 30% of the patients in the US who could potentially benefit from CAR T are getting CAR T. Now, why are they not getting access to CAR T? And there are multiple reasons. There are misconceptions. We don't understand the process. We don't understand the resources. People are scared of side effects. We feel that this is some sort of a transplant-like process, and patients who are in their 70s or 80s cannot get access to this. So there's so many reasons why people are not getting access to this treatment. And that's why I feel that it's important right now to get acts to get more information about CAR T cell therapy, especially with regards to CLL. This has been a phenomenal advance in our field. So in the next few minutes, when I advance the slides, I will explain the whole process and try to get you through what CAR T is, how does it work, and how do we go about um, administering it to our patients, what are some of the issues with it, and how do we deal with it, and what kind of responses we've seen in our patients with CLL. So now we'll advance. All right, so this is kind of how it works, all right? So I'm starting right here at the initial evaluation. The first thing to determine is that your primary oncologist or a specialist, so for example, I have the ability to be a primary oncologist. I see patients with CLL, lymphomas, and if I feel that the patient is appropriate for CAR T cell therapy, I say go. And that is an important decision. That's called a brain to vein time. And I'll explain what that means. So at some point, based on the okay. All right. So we'll definitely talk about the cost of this. There was a question in the chat. So basically, when I think about a CAR T, I have made the decision that the patient is good to go. That is a critical time point. When that decision is made, how soon do you get to CAR T? That's called a brain to vein time. The vein means the IV. When do you give the treatment, basically? So the brain to vein time has to be as short as possible. And ideally, we can control this as much as possible by planning ahead. So this is a very critical component. When the decision is made to when the patient actually gets it, because most patients who are in this time frame, they actually have um, a lot of problems. They have symptoms, the disease is not responding to treatment, they're getting sicker and sicker. So time is of the essence. We have to make sure that from the decision point to patient actually getting it, you have to go very quickly and things have to happen pretty quickly in a systematic manner. Now, I have the advantage that if I say go, the process starts right away. There's no wait time. I have coordinators, I have social workers, they're working with me closely, the nurses, and things happen rapidly. Now, on the other hand, if you are, let's say, in a small town, a few hours away, you have a local oncologist who may or may not have made the decision for you. That is now a two-step process. That person has to refer you. Sometimes insurance creates issues. You have to get a referral from your primary care doctor before you can see the specialist. But the key is to have a discussion with a specialist. Without having that discussion, you will not know whether you would even qualify for that. So once the patient gets to us, we then look at all the factors related to the patient, which basically means how good they are on paper and how good they are in person. So what does that mean? We have to make sure that their organ function is good, they have good liver, good heart, good kidneys, good lungs. We have to make sure that their bone marrow, scans, blood work, everything is done, everything is good to go. And then we decide if this patient is a suitable candidate for CAR T cell therapy. Now, when I remember when I did my first one, commercial CAR, we've been doing it for a while now, almost 10 years, but we did the first commercial CAR almost 8 years ago. And at that point, we were very nervous and we were like, oh, we're not going to do this for patients above 70. And I can tell you that last couple of months ago, I did a CAR T cell on an 89-year-old patient, and that patient did fine. And you can argue, hey, an 89-year-old, but that guy is perfectly independent, drives on his own, takes care of his stuff. He's as good as a 60-year-old. So age is definitely not something that we look at. It's the physiologic functioning of the patient that's what's most important. Similarly, people have done CAR T cells in patients in their 90s. So this is a barrier that has been almost eliminated. The age is not necessarily a barrier. At any age, as long as you're in good shape, you should be able to get CAR T cell therapy. Now, the other thing we were worried about is, hey, what about the heart function? What about the blood pressure issues? The other cardiac issues that people have. All of us will have as we get older. That's part of getting old. That again can be overcome. A lot of patients who have marginal organ function, their heart may not be perfect, their lungs may not be perfect. We routinely do CAR T on them and they do really well because we are now very comfortable in managing the issues. We have teams of people who take care of them. We have kidney doctors, we have neurologists, we have all sorts of cardiologists. We have multiple teams that manage these patients closely with us so they have the best possible outcome. All right, so this is happening when when the decision is made to move forward. And then obviously the biggest holdup here is insurance. Now, whether or not insurance companies or pharma company want us to do that, I think it's in pharma companies' best interest to get the CAR T. Why? Because still at this point, the cost of CAR T is substantial, which is a big hurdle for us to overcome. You can argue that the cost of one CAR T is equal to 10 years of other treatments. So actually, it works out very nicely for pharma companies. So it's in their interest to do this. But more importantly, it's the right thing to do. I think that's really the key. And whether or not the cost is justified or not, that's a different discussion for a different forum. And we will be talking about cost all day if we go down that road. But regardless of that issue, it is an expensive procedure. But this is why we need to get insurance approval. If you're on Medicare, Medicaid, or other insurances, we need to make sure that the insurance has agreed to cover it. Since it's an approved, FDA-approved treatment, it should not be an issue for the vast majority of patients. I remember the first one we did, our CFO had to sign off on it because everybody was worried about the cost and how will the hospital be able to manage it. Now we've figured out all sorts of contracts with various insurance companies. A lot of our centers like us are what are called preferred centers because we've done so many of them, hundreds of these patients, so that we have a well-established track record and it's easy for us to get those insurance authorization pretty quickly, but it can take up to 4 weeks. So this is where the longest delay happens. Patients get to us, gets an appointment, gets the assessment done of how fit they are, and then get the insurance approval. And the next thing we do is cell processing and collection. So what does that even mean? What is CAR T cell exactly doing? So CAR T cell is basically just waking up the immune system. So basically, we tell the patient's immune system, hey, guys, wake up and fight the cancer. You are the good policeman in the body, but you have allowed the cancer to progress. And the response we get from these T cells or the patient's immune system is, hey, we don't have the tools, we don't have the guns, we can't fight this cancer, so we're not going to fight it. So that's essentially why the cancer grows. And a lot of focus over the years has been on how we can activate the immune system inside the patient so the patient's immune system can actually fight the cancer. And that's what the issue is with most cancers, because the body's own immune system, for whatever reason, has stopped fighting the cancer. And so we ask these guys, hey, why don't you wake up and fight it? And these guys say, oh, we don't have the guns, we don't have the bullets, and fine. Okay, so we're like, okay, fine. How about you come with us? So basically, we take out the immune system cells. That process is called cell collection or harvesting. Now, what does that mean, the harvesting? What does it look like? Basically, patients come in, we have an IV in one arm, sometimes an IV in both arms if they have good veins. If they don't have good veins, they can sometimes get a catheter. It's essentially like, I don't know if you guys have donated platelets, and when you go to donate platelets, in the blood bank, they will put an IV in, they will take the blood out, they will spin it, they will give you back your blood, and they will take out the platelets, and then the platelets go to the patients. Similarly, for CAR T cell therapy, it's the same exact process. It takes 4 to 6 hours. We take the blood out, put it through a machine. The machine separates the immune system cells, and a few cells are taken out. The blood is returned to the patient. The patient is watching TV, and they go home at the end of the day. 4 to 6 hours, done. So that process is called harvesting. So basically, what we did was we took out the lazy immune system cells which are not working. Now, those cells are then shipped to what we call a factory or a manufacturing center. Now, what happens in that center is they get the cells wherever that factory is, and they say, guys, you need to wake up. And but then same excuse. These T cells or the immune system cells say we don't have the guns. So what do? We insert a gun in their surface. So now they have a gun. That gun is specifically designed to kill the cancer. That's its only function. So now all of these immune system cells are activated, and they have this new gun which targets the cancer, and they are now ready to kill the cancer cells. So this whole process is called transduction and so on. Multiple tools, multiple techniques are used to induce this expression on the T cells. So we can insert it through various vectors, through viruses, and so on. Once we have, let's say, 100 cells, we say, okay, fine, are you ready to fight? And they were like, yeah, we're ready to fight, but there aren't enough of us. So what do? So we take those, let's say, 100 cells, and then we make a whole army out of them. And that process is called expansion. So you expand the number of CAR T cells, all primed, ready to kill the cancer cells. So they have the same gun that is done. Now, this takes time. This takes up to 3 weeks, 17 to 21 days in that ballpark. While this is happening, remember, I made the decision to go to CAR T a month ago, saw the patient, said go, they got testing done, they got the insurance approval, everything's ready to go. So it's already been a month before harvesting, and now another 3 weeks. So now we're ready at week 8. What's happening with the cancer at this point? I have to control the cancer. And this is when I would need to use some sort of what we call bridging treatment. It's like what we can say maybe some sort of treatment that controls the cancer. Because remember, if we have this much cancer, it's easy to kill it rather than if you have this much cancer. So if you have, let's say, 100 million CAR T cells at the end, if you give them 100 million cancer cells to fight, that's going to be a big battle. But if you have this many cancer cells, these cells have a pretty good chance of killing it all. So this is why during this whole journey, we have to control the cancer and not allow the cancer to grow. This process is called bridging treatment. So during that time when we are manufacturing, we are harvesting, we are transducing, we are expanding, we need to control the disease. So various methods are used, pills, IVs, chemo, non-chemo. We can use all sorts of things to control treatment, to control the cancer by various treatments, and this is called bridging treatment. Eventually, we get the cells back. It's a small vial, it can be 10 cc's, it can be 60 cc's, so very small amount. Millions of dollars worth, okay? That's where the pharma makes money, but that's besides the point. The point is that it's a very unique tool that can cure a lot of our patients. That can be frozen, that can be fresh, depending on the situation, depending on the product, and then we are ready to go. When we are ready to go, we then say, okay, fine, right before I give you the CAR T, I give you 3 days of chemotherapy. Now, this is not high doses of chemotherapy. This is just a small amount of chemo. The idea is to suppress the existing bad immune cells and then sneak these new guys in on the 5th day. After you give 3 days of small doses of chemo, patient comes in, gets the chemo, goes home, comes in, gets the chemo, goes home. It's 3 days in a row. A couple of days later, we give them the cells. Just like an IV in the blood, nothing to it, takes 10-15 minutes, and you're done. Those cells are now primed to kill the cancer cells. And just before they are given, the chemotherapy reduces the um, immune system so that their body's own immune system doesn't fight these cells. All right. And then based on certain other factors, it also allows for these cells to now grow when they get inside the body. So that's called expansion. And I'll talk to you more about it. So this is called lymphodepleting chemotherapy and then CAR T cell reinfusion. And then once that fighting happens, all the badness, side effects, all of them, chemotherapy side effects can sometimes happen because people can get nausea, can have low blood counts, and so on. So they can have some problems with the small doses of chemotherapy. And obviously, when the cancer cells are being killed by these good guys, there will be some side effects. And that's what the problem has historically been. How do you manage those side effects? And then these cancer cells hopefully are all eliminated by the T cells, and the patients can go home in a couple of weeks. Now, during this time, the patients are seen on a daily basis. It can be done as an outpatient, can be done as an inpatient. Historically, some centers have done it all as an inpatient, so patients are in the hospital for 7 or 10 days. Other centers do it as an outpatient. We have, for example, I can give you our example. We have apartments down the street. We have hotels. We have issues that we deal with right away. And basically, patients are managed right away as soon as there are issues. So lymphodepleting chemotherapy is considered standard of care. There are various ways to cut down on the chemotherapy, change chemotherapy, and right now we're not quite there yet. So for most practical purposes, chemotherapy is fairly similar for all CAR T cell therapy. It's a standard 3-day chemotherapy regimen that has shown to work nicely for these patients. So this is all considered standard of care. CAR T cell is considered standard of care now. So all of this goes through regular insurance. Now, if there is a new CAR T cell product, now, for example, there are multiple CAR T cell products that have 2 guns, and then I have different guns. So this is all being developed. So, there's multiple different CAR T constructs. So we are trying to do that, and then hopefully we can also change the lymphodepleting chemotherapy, and instead of giving chemotherapy, we can give something else to suppress the immune system. So people are working on it, we're working on it, and that's a work in progress. So essentially, the big problem that happens with CAR T is not until the CAR T infusion. That's when all the problems typically happen. Any side effects, any fevers, any of those issues that we see which make CAR T very scary. And that's one of the reasons why patients don't get to us for CAR T cell evaluation, because of these reasons. So this is what we have to do to work with the community partners to allow patients to get access to this treatment. We have to educate the patients on what to expect. When do you go for CAR T cell therapy? What is the right timing for that? And who is the one that you need to work with closely? And is that logistically possible? Do you have caregiver support? You have to stay close to that CAR T centers for at least 2 weeks so you can recover from any acute problems like fevers, like infections, and so on. Any side effects need to be managed very aggressively. You won't be able to drive for at least 2 weeks after CAR T cell therapy. So those are things that have to be explained to the patient so that they know what they're getting themselves into. Now, some of these side effects can be severe, just like with any treatment. And this is why you need to be in a specialized center that has access to apheresis or harvesting, that has access to ability to reinfuse, collect the cells, thaw the cells, and so on, and then manage the side effects of treatment. So this is where we need to educate the patients, and also not just the patients, the patient's oncologist who's referring the patient needs to be educated. And then once the patient gets back to his home place or home base, they also need to be ready to handle any delayed side effects. Now, most of the problems will happen in the first couple of weeks, and hopefully the patients would have recovered fine. But sometimes, delayed side effects can happen. Patients also would need vaccinations. People would need protection against infections and aggressive treatment of their infections. This is exactly why we need to have a very strong partnership from the um, um, with the referring physician, I was reading the question, so I'll get to that in a second. So we need to have very important partnerships with the local team and also with the team that is doing the CAR T. If it's the same team, it makes it so much easier. But a lot of times, we realize that a lot of patients who are far away from the primary CAR T centers may not even get access. So this is where discussions with the community partners is so important to allow patients to safely get back to their home base. All right, so this is kind of another way of seeing what happens. So you get the cells on what we call day zero. So remember, you got 3 days of chemotherapy right here, day -5, -4, -3. You get day -2, day -1 off. So you're basically at home on those 2 days. And then on day zero, you get the cells. Like I said, 10, 15 minutes is all it takes. And then because of the effect of the chemo, the body is now trying to recover from the chemo. While it's recovering from the chemo, those kind of things help the expansion of the CAR T inside the body. And when they expand, they're now fighting the cancer. When they're fighting the cancer, side effects happen. And we'll go into all of that in detail in a bit. And those two main ones are called CRS or ICANS. So one of them is fevers, just to put it simply, and the other one is neurotoxicity or neurological issues. All right. So, but basically, all of these happen pretty quickly after the CAR T cell therapy. Sometimes the neurotoxicity can be delayed for up to 30 days, but generally within 2 weeks, this action happens and the patients typically will recover. Now, the CAR T cells can persist in some cases for longer time, and that's why they keep working against the cancer and hopefully cure it in those patients. Now, sometimes they go away within 4 weeks and they are gone from the body, but in some cases, they do persist for a long period of time. And that's how you basically cure patients. So if the cancer is gone and the cells are gone, that's fine, no problems. But if there's a little bit of cancer left, a persisting CAR T clone can continue to slowly work against it and kill it. So this is kind of how the whole process happens. The first 2 weeks close, and then it's a much less intense follow-up. All right, so let's talk mostly about CRS and neurotoxicity. What is this? So in simple terms, the two main side effects are CRS and neurotoxicity. CRS is essentially inflammation response, a cytokine release syndrome. Basically, after the cells are in place in the body, they start fighting the cancer. As they start fighting the cancer, there's a slew of cytokines that are released. Those are all what we call inflammatory cytokines. They cause fevers. For example, there's IL-6, there's TNF alpha, and there's interferon gamma, and so on. There's so many different chemicals that are released during this killing process that causes a lot of inflammation in the body. Now, as a result, people can have fevers. Now, this is not your Tylenol fever. Tylenol does help, but it's not something that can be controlled by just simple anti-inflammatory drugs. And you need specialized care. You need to know when to expect it, what to do, and we also have to make sure that it doesn't get severe. That's the key. And this is why we use steroids. This is why we use these medicines that are designed against that specific cytokine. For example, for IL-6, we use tocilizumab. This is a specialized medicine that is used specifically for this, and it's a dose that we can give every 8 hours. That has to be done in the hospital. In severe cases, patients can have low blood pressure, and that's when they would need to be in the ICU for monitoring. And for blood pressure support, they would need fluids to bring the blood pressure up. So they will need very close monitoring, and sometimes they can have low oxygen levels, so they would need oxygen. So there are these degrees of CRS, and the most common ones, fortunately, are the ones that are slight fevers and maybe feeling shortness of breath. Now it gets worse and worse in some cases, and that's when you need specialized care. The point of this is, yes, it sounds scary, but this is exactly what we expect. We expect that some of our patients, especially for those patients who have a lot of cancer, because there's going to be a lot of fighting in the body, they can potentially have these complications. This is why you need to have teams in place to handle the worst case scenario. We understand that the vast majority of patients, we know that the vast majority of patients won't have these issues, but we can't assume that everyone will be fine. So this is when we basically have the ICU team, the pulmonary team, and the neurology team, the kidney team, all of them on board, so that in case something happens, we are ready to handle the side effect. And this is the critical piece. When you're going in with CAR T, you have to be ready to be aggressive on it, because you want to make sure that our patients have the best possible chance of recovery from whatever complication you have. You cannot do these half-baked, so to speak. You have to be all in. You have to have the most aggressive care, especially during the first 2 weeks, and make sure that the patient goes through it safely. And the vast majority of patients all over the country are able to make it through the CRS. In fact, this has been looked at. Very rarely do patients die from CRS and neurotoxicity. It's a very small percentage, less than 3%, and varies from center to center. So it's not zero, but it is not a very common thing. The vast majority of patients who actually have problems are the ones who have the disease come back very rapidly. So cancer is the biggest problem with or without CAR T. So this is what CRS is. Now let's talk about neurotoxicity. Neurotoxicity sounds very concerning. The vast majority of patients who have neurotoxicity, the most common thing I see is patients getting confused. They may not know exactly where they are. Actually, we've had multiple patients who you walk in the room, you're talking to them fine, the weather looks good, how do you feel? I feel okay. Did you sleep well? If you talk to them about life issues, general things, they may actually answer perfectly reasonably well. But this is the key. We don't want to ask them the general life questions, which sometimes people can fake and not even know that they have a problem. This is why we have to have a structured question and a set of questions for them. And we ask them specific questions like, what's 100 minus 7? What's this? What's that? We ask them factual questions. And this assessment is done on an ongoing basis for patients who are undergoing this. So this is done consistently, either if you're in the hospital or outside the hospital, every day or every few hours. If you're in the hospital, the nurses know exactly how to administer this, and the patient has to write a sentence. So sometimes we can even see that the writing is suffering. So that could be a very subtle sign that something neurologic is happening. Now, in the worst case scenario, they can get completely confused, and in some cases, that can result into seizures. But that's very uncommon. So this is why we put patients on seizure prevention medicines in a lot of cases. So these are all things we, again, predict. Neurology is aware. We do MRIs of the brain. We know what it looks like up front. We assess their mental function, and then we reassess them multiple times. So we keep a very close eye. And if they start getting any evidence of confusion or any problems with their neurological function, we can treat them appropriately with different drugs like steroids. We can give them other medicines like anakinra and so on. This is something that we will keep a very close eye on. This is another reason why we want them to be with a caregiver, so that that person can assess the patient's condition and get help if the patient is unable or not willing to do that because they may not be thinking right. So, because sometimes it can be very subtle. This is also part of the reason why the first 2 weeks we discourage or don't allow the patients to drive, and also to be careful if they're in a profession where they have to operate heavy machinery and anything that can put them at risk. So these are kind of the things that we watch for. In vast majority of cases, both CRS and neurotoxicity is very reversible. Like I said, in the vast majority of cases, they are very subtle and low grade, and patients are perfectly fine after treatment. And after 30 days or so, we don't see these issues at all. Even after 2 weeks, we hardly ever see CRS, and neurotoxicity is also uncommon after that, but can happen sometimes. So that's why you have to keep an eye on it. But all of these issues are typically reversed before we release the patient back to go to their home base. Or if they're with us, we follow them very closely the first 2 weeks, and then we space out the follow-ups after the first 2 weeks. And then based on how they do, A month later, we slow it down even more. Has anybody had irreversible neurological toxicities? Obviously, there can always be really bad complications. Again, like I said before, most of these side effects are seen mostly in patients with aggressive, high risk disease with a lot of disease at the time of CAR T. The more cancer cells you have, the more side effects that you have. It's as simple as that. Can we move this treatment up front? Now I'll share some data with you. Just again, I understand that we're not going to be experts in this, but just to show you where we are right now and how we can move it forward. In some diseases, we are actually doing clinical trials to use this up front. One shot, you're done. Now, obviously, at that point, we have very good treatment for a lot of our patients. Remember, for CLL, maybe we're not curing patients, but in a lot of patients, we control the disease and they die of old age. So we never have to worry about them needing a CAR T cell therapy. For some aggressive disease, like large cell lymphoma, in which CAR T is also approved, 60 to 70% can be cured with whatever chemotherapy that you use. So this is why you don't want to use treatment that may even slightly decrease the chances of a cure rate of less than 60 or 70, or what's already established. You want to make sure that the cure rates are preserved or improved by the use of CAR T. Secondly, when the patients first start off, they typically have a lot of disease. So you have to have some way to shrink it before you start doing CAR T cell therapy at the time of diagnosis for everyone. Now, there are trials ongoing for myeloma, for lymphoma, in which CAR T cell therapy is done as frontline treatment, first treatment, after you shrink the disease and then go straight. So this is something that is being tested. It may make it, depending on how well tolerated it is and what kind of side effects we see. But at the same time, for aggressive diseases, we don't want to jeopardize cures. For slow growing diseases, we don't want to create more trouble for the patients through side effects. So this is why the field is slowly moving towards this in the frontline setting, but not quite there. All right, so let's move on to CLL. So there's one CAR T cell that's approved. It's called Lysocell, lysocaptogene. And this was basically based on this trial called the CLL-04 trial. So basically, we did lysocell manufacturing, same thing, bridging, and then we added fludarabine and cyclophosphamide, the 3 days of chemotherapy, and then we gave the CAR T cell therapy. So similarly to what we would do for any other CAR T. And in the first trial, again, I don't want to confuse you here, but the bottom line of this is that it was for patients who had really bad disease, who had failed all previous lines of treatment. So in the first iterations, we saw that this group of patient actually does well. But turns out that's only 20% of the patients. So, exciting responses, but not like earth-shattering. I mean, we're not curing everyone here. These are patients who have really bad disease. And in those, we are maybe looking at 20% of the patients who don't have the cancer come back. In every other patient subset, the cancer keeps coming back. So what's unique about this group, this group in blue, in which the cancer doesn't appear to be coming back as much? And turns out that these patients had a complete remission after CAR T, which means that all the lymph nodes went down, the spleen normalized, and there was no sign of cancer in the blood. So the deeper the remission at 30 days out and 1 month out and 3 months out of CAR T, so you do the CAR T, you do another evaluation at 30 days, you do another evaluation at 90 days, both of those show that the patient achieved a very deep remission. And those are the ones that actually did well. Anybody else who had a little bit of disease, even if they had, let's say, this much disease, they shrank to this much at 30 days, the disease slowly comes back. So you have to have patients who go from here to zero. In those patients, then you can possibly say, hey, the disease is not coming back for 2 years, 3 years out. Some of these patients are now 5 years out and the cancer hasn't come back. So the next question you ask me is, when do you call it a cure? Nobody knows the answer to that because it's only been around for a few years. Will you call it a cure if the cancer doesn't come back for 5 years? Will you call it a cure when the cancer doesn't come back in 10 years? Nobody knows the answer to that. Once we get that answer, we will hopefully say, okay, fine, it's curing X percentage of patients. But right now, the first iteration of this was done a few years ago, and it showed that 20% of the patient had long remission after that one dose of CAR T cell therapy, but those are the patients who had a good response treatment. So then people were like, yeah, it's exciting, but can we do better? And that's constantly our effort. So how can we do better? So we basically added another drug called ibrutinib, which is a drug which we use frequently as bridging. We use it to buy time so the patients can get all the things they need to get to CAR T. Now, why ibrutinib? Ibrutinib actually improves the health of the T cells. So it basically tells the immune system to start fighting more aggressively. And we found out that we went from a CR rate of 20% to almost a 45%. So almost double possibly the cure rates. Remember, the ones who go into a complete remission are the ones who do well. Almost 90% of the patients had a response, but the deep response, the ones that do really, really well, actually are the ones who may have long remissions and possibly cures. So this is why by just adding a drug for 1 month and 3 months total, before and after CAR T cell, made a huge difference. And why is that? Because it's not that that drug is necessarily controlling the cancer. It's because that drug is allowing the T cells to be more aggressive, more active against the cancer. So this is just one of the things that people have done. We're doing multiple other trials. We're combining different things. The bottom line is that these kind of approaches are what will hopefully allow us to shrink the cancer much more aggressively, and then hopefully um, will do well in the long run. All right, so there's a question here that and a colleague of mine who went through CAR T stayed in the hospital for a whole month for tight observation. She said 1 month of the hospital is the CAR T standard in Italy. What is the period of hospital say so short in the US? Yes. So when we started doing CAR T cell therapy, like I said, 10 years ago, we were also keeping the patients in the hospital for 3-4 weeks. Now we don't. We are very comfortable. We have the resources to manage patients as an outpatient. We do hundreds of these. So as you get more experience and more comfortable, you can cut down on these requirements. So it's just a function of getting more comfortable with it, having the processes in place to manage the patients as an outpatient, and most patients would not need to be in the hospital that long or at all. Actually, a lot of centers are doing CAR T cell as an outpatient. We are also trying to transition as an outpatient, except because of our logistic issue, a lot of our patients come from long distances. So we actually have apartments that some of these patients can stay at. But we expect that over the next few years and few months, most of our patients will get it as an outpatient, and they will be seen on a daily basis, and then they can sleep in their own bed and actually do just fine. So it's all about comfort level, having the processes in place. Another example was when we started off, we would not allow people to drive for a month or 90 days or somewhat. Now we know exactly which patients will do poorly, so that's why the driving restrictions are not there. We also wanted patients to have a caregiver for 3 months initially, a full-time 24/7 caregiver. Now we don't require that. At most, it's a month. And then when they're in the hospital, they don't even need to have a caregiver, but when they go home, they just need to have it for 2 weeks. So these are things that as we evolve, patients would not need to be monitored as aggressively, since we are very comfortable with managing the side effects. This is where I was talking about the partnership between the community and the primary centers. So another question that was asked was, how long do you take the ibrutinib? So you take the ibrutinib for a total of 3 months around the CAR T cell therapy. Again, that is primarily to not because we feel that ibrutinib would work in these patients, because most patients who get to this stage have had ibrutinib before, and ibrutinib has stopped working for them generally. That's why we do the CAR T cell therapy. But this is designed to improve the activity and the function of the T cells that we harvest from the patient. So 3 months total of ibrutinib. So hopefully most patients are able to handle it just fine without any major side effects. Any other questions? So I've talked a lot.
I think that was incredibly informative. We do have just a few moments if anyone has an extra question. Um, Or Padma asked, can you explain bridge treatment again?
Sure, sure. Again, bridge treatment is designed to control the disease to keep the disease under control while we're getting the CAR T cells manufactured. So the manufacturing is happening in the factory. It takes around 3 to 4 weeks. Sometimes the manufacturing may not work, so you have to do the whole process again. During this time, you have to control the disease somehow, and there's multiple strategies. You can do various things. We typically avoid chemotherapy during that setting, but if we have to use it, we can use it. But generally, bridging therapy is considered treatment to control the disease while we're getting everything set up. Um, and we can basically get all the things in place for the CAR T to actually happen. So bridging is just, like I said, it's like a band-aid treatment just to get us to the final thing without letting the disease out of control.
And, and then this is another interesting one. Kat asks, if ibrutinib helps keep the CAR T cells healthy, why would you stop it at 90 days?
Great question. So because again, like I showed you the curve, most of the CAR T cells are gone out of the system by that time. Number one. Number two, ibrutinib also has side effects, and it can cause problems of its own. That's why we don't want patients to be on it. And that defeats, again, the whole purpose. We want to make sure that it's a one and done. You can get the CAR T, and if you go into remission, hopefully you will never have to get any treatment again. So we're trying to move away from any sort of maintenance after CAR T because we want the CAR T to function. We want that to be effective. So ibrutinib is designed to be in the system around right before harvesting and through the process, but then eventually stop it so you don't have to have the side effects of ibrutinib or any complications from ibrutinib. And then by then the CAR T cells are automatically gone anyway.
Okay. And then I know we are at time, but we had one more question come in. Um, is the treatment journey that you outlined for CLL pretty similar for other diseases such as myeloma or lymphoma?
Yeah, so these are all related questions. The treatment journey for all CAR T is the same, exactly the same process for all CAR T cells, whether be it for myeloma, lymphoma, leukemia, CLL, ALL, lupus, myasthenia gravis, you name it, multiple sclerosis, all the CAR T cell journeys in which you use your own T cells, it's fairly similar. There is a shift, agreed, to bispecifics, and bispecifics are being used more and more. Why is that? Because it's an ongoing treatment. It doesn't require that kind of logistical harvesting support that CAR T requires. But again, bispecifics are continued perpetually. So that's the disadvantage. The other advantage of bispecific is it's off the shelf. If you want to start tomorrow, you get approval and you start tomorrow. So there are some advantages and some disadvantages of bispecifics. Will bispecifics result in long sustained remissions? We still need to know that, whether it will possibly cure some patients if it works, and some patients have long remissions and you stop treatment with bispecifics and they continue to get long remissions, that would be very exciting. But these are all questions that are being addressed. But the access is something that we can do for all of these. So a couple of other questions very quickly. What about Jaypirca prior to CAR T cell therapy? What about ibrutinib? Ibrutinib can be used as a bridge. Absolutely. If you have sensitivity to ibrutinib, it can be used both as a bridge and also to help the T cells. Most people will be resistant to ibrutinib, so it may not be very effective for a bridge. So if you want ibrutinib to be used as a bridge, if you are ibrutinib refractory or ibrutinib doesn't work, you would have to combine something with ibrutinib. Now, a lot of people are on pirtobrutinib or Jaypirca right before CAR T cell therapy. Does pirtobrutinib does the same thing as ibrutinib? We just don't know. So for those patients, in my cases, right before I start them on the T cell harvesting, I would probably switch them over to ibrutinib. These are things we don't know, to be honest. Everyone does it differently right now. Will Jaypirca have the same outcomes as ibrutinib? We just don't know. It all depends on the situation. It all depends whether you're able to handle the ibrutinib and what kind of disease processes you have. Can you afford being off the Jaypirca or pirtobrutinib for a few days while you're getting on the ibrutinib? Again, it's not that ibrutinib would control the disease necessarily. In most patients, it's mostly for the T cell function. That's why we prefer to use ibrutinib. Will Jaypirca do the same thing? We will find out in the future.
Awesome. Well, thank you so much for your time. This was incredibly informative, and um, just thank you. CAR T is a very exciting new therapy, not just in CLL, but I think everyone here is pretty interested in the CLL aspect. So thank you for covering this, and just a really great seminar. So thank you for your time.
Thank you all. Have a good one.
Excellent. All right. And I just have a couple of things before we wrap up today. I wanted to let everyone know that we do have a end of year fundraising campaign that we're running here at HealthTree. So if you are interested in donating, we do have that option available. And if you do donate to this campaign, it really helps us drive forward our research and our capabilities that we have here at HealthTree. We're really trying to revolutionize what we're able to do using patient data and really help work with researchers to accelerate cures. So if you're interested in either donating financially, we have that option there, but also just sharing our resources with people that you think would benefit from our stuff. Getting word of mouth out there is always a big help as well and greatly appreciated. Or if you want to partake in some research studies or work with some researchers, connecting your medical records is another great opportunity to get involved and get connected here at HealthTree. So anything that you can do is wonderful. And we appreciate you all for your time and your consideration. And then we do have some upcoming events that I wanted to highlight. So on November 4th, we have Overcoming Insurance Pre-Authorization Delays and Denials, a patient guide to faster blood cancer care. On November 6th, I have When to Start CLL Treatment with Dr. William Weirda out of MD Anderson. And then on November 14th, we have Empower Your Mind, Journaling to Build Resilience for Patients and Caregivers. So some really good events coming up. And then one final thank you to our CLL Central sponsor, AbbVie, for sponsoring this event. Again, we wouldn't be able to do these types of events without their support. And finally, a big thank you to everyone for joining today. We do have that survey. If you could take a moment to fill that out, it really does help us when trying to plan what matters to our community. So please take a moment to fill that out. It is greatly appreciated. Additionally, I will be staying on for a couple of moments if you would like the opportunity to speak with me or perhaps any other patients that are staying on. I'm really wanting us to become a close-knit community here. So if you're interested in that, please feel free to stay on and chat with me for a few moments. And one final thing that I wanted to bring up is we are getting ready to launch surveys in other blood cancers, including CLL. And I am in the process right now of pulling together a patient review board for our CLL survey. This is going to be examining what matters when deciding a treatment. So if you want to do fixed or continuous duration therapy, and we're really looking to get a patient perspective on that. So if you are interested in being part of that review panel, please feel free to reach out to me or stay on afterwards and I can grab your email. Um, and it should be a really good opportunity. We are partnering with Dr. Deborah Stevens for this. So have a wonderful medical doctor who's partnering with us on this survey. And I think it should be a really good one, but want to make sure we get that patient voice right. So if you're interested, please feel free to reach out to me. But with that, I'm going to go ahead and wrap it up. I'll turn off the recording, but I'll keep the Zoom open if anyone would like to chat with me.